Chapter 5, the Integumentary System, Types of Skin. The objective of this section is to compare the structural and functional differences in thin and thick skin. Although the skin over the entire body is similar in structure, there are quite a few local variations related to thickness of the epidermis, strength, flexibility, degree of keratinization, distribution and type of hair, density and types of glands, pigmentation, vascularity, and innervation. Two major types of skin are recognized on the basis of certain structural and functional properties: thin, hairy skin and thick, hairless skin. In this next section, I have a comparison of thin and thick skin. We will discuss distribution, epidermal thickness, epidermal strata, epidermal ridges, hair follicles and arrector pili muscles, sebaceous glands, subduriferous glands, and sensory receptors. The distribution of thin skin is to all parts of the body except areas such as the palms and palmar surface of the digits and soles. While the distribution of thick skin is in areas such as the palms, palmar surface of digits, and the soles. The epidermal thickness of thin skin is 0.1 to 0.15 millimeters, which is 0.004 to 0.006 inches. The thickness of epidermal thick skin, so the epidermal thickness of thick skin is 0.6 to 4.5 millimeters, or 0.024 to 0.018 inches. In the epidermal strata, the thin skin is the stratum lucidum, essentially lacking thinner strata, spinosum and corneum, while the thick skin is the thick strata lucidum, spinosum, and corneum. The epidermal ridges of thin skin lacking due to poorly developed and fewer and less well-organized dermal papillae, while in thick skin it's present due to well-developed and more numerous dermal papillae organized in parallel rows. Hair follicles are present in thin skin while they are absent in thick skin. Sebaceous glands are present in thin skin and absent from thick skin. Subduriferous glands are fewer in thin skin and are more numerous in thick skin. Sensory receptors are sparser in thin skin and they're denser in thick skin. So to summarize, thin skin is in all parts of the body except areas such as the palms and the palar surfaces of digits and soles. It is between 0.10 and 0.15 millimeters thick. The stratum lucidum essentially lacking thinner stratum spinosum and corneum. The epidermal ridges are lacking due to poor developed and fewer and less well-organized dermal papillae. Hair follicles are present, sebaceous glands are present, subduriferous glands are fewer, and sensory receptors are sparser. The distribution of thick skin is in areas such as the palms, palmar surface of digits, and soles, every place that it's lacking, that the thin skin is not. The thickness is 0.6 to 4.5 millimeters. The epidermal strata, the thick strata lucidum, spinosum, and corneum. The epidermal ridges are present due to well-developed and more numerous dermal papillae organized in parallel rows. Hair follicles are absent, sebaceous glands are absent, subduriferous glands are more numerous, and sensory receptors are denser. As you would imagine, because it's on your fingers and toes. Okay, so the function of the skin. Describe how the skin contributes to the regulation of body temperature, storage of blood, protection, sensation, excretion, and absorption, and synthesis of vitamin D. Now that you have a basic understanding of the structure of the skin, you can better appreciate its functions, which were introduced at the beginning of this chapter. The numerous functions of the integumentary system, mainly the skin, include thermoregulation, storage of blood, protection, cutaneous sensation, excretion and absorption, and synthesis of vitamin D. Thermoregulation. Recall that thermoregulation is the homeostatic regulation of body temperature. The skin contributes to thermoregulation in two ways, by liberating sweat at its surface and by adjusting the flow of blood in the dermis. In response to high environmental temperatures or heat produced by exercise, sweat production from eccrine sweat glands increases. The evaporation of sweat from the skin surface helps lower body temperature. In addition, blood vessels in the dermis of the skin dilate. They become wider. Consequently, more blood flows through the dermis, which increases the amount of heat loss from the body. In response to lower environmental temperature, production of sweat from eccrine sweat glands is decreased, which helps conserve heat. Also, the blood vessels in the dermis of the skin constrict, becoming narrower, which decreases blood flow through the skin and reduces heat loss from the body. Blood reservoir. The dermis houses an extensive network of blood vessels that carry 8 to 10% of the total blood flow in a resting adult. For this reason, the skin acts as a blood reservoir. Protection. The skin provides protection to the body in various ways. Keratin protects underlying tissues from microbes, abrasions, heat, and chemicals, and the tightly interlocked keratinocytes resist invasion by microbes. Lipids released by lamella granula inhibit evaporation of water from the skin surface, thus guarding against dehydration. They also retard entry of water across the skin surface during showers and swims. The oily sebum from the sebaceous glands keeps skin and hair from drying out and contains bactericide, chemicals that kill surface bacteria. The acidic pH of perspiration retards the growth of some microbes. The pigment melanin helps shield against the damaging effects of ultraviolet light. Two types of cells carry out protective functions that are immunological in nature. Two types of cells carry out protective functions that are immunological in nature. Epidermal Langerhans cells alert the immune system to the presence of potentially harmful microbial invaders by recognizing and processing them. And macrophages in the dermis phagocytize bacteria and viruses that manage to bypass the Langerhans cells of the epidermis. Cutaneous sensations. Cutaneous sensations are sensations that arise in the skin, including tactile sensations, touch, pressure vibrations, and tickling, as well as thermal sensations such as warmth and coolness. Another cutaneous sensation, pain, usually is an indication of impeding or actual tissue damage. There's a wide variety of nerve endings and receptors distributed throughout the skin, including the tactile discs of the epidermis, the corpuscles of touch in the dermis, and hair root plexus around each hair follicle. Chapter 16 provides more details on the topic of cutaneous sensation. Excretion and absorption. The skin normally has a small role in excretion, the elimination of substances from the body, and absorption, the passage of materials from the external environment into the body cells. Despite the almost waterproof nature of the stratum corneum, about 400 milliliters of water evaporate through it daily. A sedentary person loses an additional 200 milliliters per day as sweat. A physically active person loses much more. Besides removing water and heat from the body, sweat also is the vehicle for excretion of small amounts of salts, carbon dioxide, and two organic molecules that result from the breakdown of proteins, ammonia and urea. The absorption of water-soluble substances through the skin is negligible, but certain lipid-soluble materials do penetrate the skin. These include fat-soluble vitamins A, D, E, and K, certain drugs, and the gases oxygen and carbon dioxide. Toxic materials that can be absorbed through the skin include organic solvents such as acetone and some nail polish removers and carbon tetrachloride, dry cleaning fluid. Salts of heavy metals such as lead, mercury, and arsenic, and the substances in poison ivy and poison oak. Since topical applied to the skin, steroids such as cortisone are lipid soluble, they move easily into the papillary region of the dermis. Here, they exert their anti-inflammatory properties by inhibiting histamine production by mast cells. Recall that histamine contributes to inflammation. The clinical connection. Transdermal drug administration. Most drugs are either absorbed into the body through the digestive system or injected into subcutaneous tissue or muscle. An alternative route, transdermal or transcutaneous drug administration, enables a drug contained within an adhesive skin patch to pass across the epidermis and into blood vessels of the dermis. The drug is released continuously at a controlled rate over a period of 1 to several days. This method of administration is especially useful for drugs that are quickly eliminated from the body, because such drugs, if taken in other forms, would have to be taken quite frequently. Because the major barrier to penetration of most drugs is the stratum corneum, transdermal absorption is most rapid in regions of the skin where this layer is thin, such as the scrotum, the face, and scalp. A growing number of drugs are available for transdermal administration, including nitroglycerin for the prevention of angina pectoris, chest pain associated with heart disease, scopolamine for motion sickness, estradiol used for estrogen replacement therapy during menopause, ethinylestradiol, and norelgestromin in contraceptive patches, nicotine used to help people stop smoking, and fentanyl used to relieve severe pain in cancer patients. Synthesis of vitamin D. Synthesis of vitamin D requires activation of a precursor molecule in the skin by ultraviolet rays in sunlight. Enzymes in the liver and kidney then modify the activated molecule, finally producing calcitrol, the most active form of vitamin D. Calcitrol is a hormone that aids in the absorption of calcium in foods from the gastrointestinal tract into the blood. Only a small amount of exposure to UV light, about 10 to 15 minutes at least twice a week, is required for vitamin D synthesis. Maintaining homeostasis, skin wound healing. The object of this section is to explain how epidermal wounds and deep wounds heal. Skin damage sets in motion a sequence of events that repairs the skin to its normal or near normal structure and function. Two kinds of wound healing processes can occur, depending on the depth of the injury. Epidermal wound healing occurs following wounds that affect only the epidermis. Deep wound healing occurs following wounds that penetrate the dermis. Epidermal wound healing. Even though the central portion of an epidermal wound may extend into the dermis, the edges of the wound usually involve only slight damage to superficial epidermal cells. Common types of epidermal wounds include abrasions, in which a portion of the skin has been scraped away, and minor burns. In response to an epidermal injury, basal cells of the epidermis surrounding the wound break contact with the basement membrane. The cells then enlarge and migrate across the wound. The cells appear to migrate as a sheet until advancing cells from the opposite sides of the wound meet. When epidermal cells encounter one another, they stop migrating due to a cellular response called contact inhibition. Migration of the epidermal cells stops completely when each is finally in contact with other epidermal cells on all sides. As the basal epidermis cells migrate, a hormone called epidermal growth factor stimulates basal stem cells to divide and replace the ones that have moved into the wound. The relocated basal epidermal cells divide to build new strata, thus thickening the new epidermis. Deep wound healing. Deep wound healing occurs when an injury extends to the dermis and subcutaneous layer. Because multiple tissue layers must be repaired, the healing process is more complex than an epidermal wound healing. In addition, because scar tissue is formed, the healed tissue loses some of its normal function. Deep wound healing occurs in 4 phases: an inflammatory phase, a migratory phase, a proliferative phase, and a maturation phase. During the inflammation phase, a blood clot forms in the wound and loosely unites the wound edges. As its name implies, this phase of deep wound healing involves inflammation, a vascular and cellular response that helps eliminate microbes, foreign material, and dying tissue in preparation for repair. The vasodilation and increased permeability of blood vessels associated with inflammation enhance delivery of helpful cells. These include phagocytic white blood cells called neutrophils, monocytes which develop into macrophages that phagocytize microbes, and mesenchymal cells which develop into fibroblasts. The 3 phases that follow do the work of repairing the wound. In the migratory phase, the clot becomes a scab, and epithelial cells migrate beneath the scab to bridge the wound. Fibroblasts migrate along the fibrin threads and begin synthesizing scar tissue, collagen fibers, and glycoproteins. And damaged blood vessels begin to regrow. During this phase, the tissue filling the wound is called granulation tissue. The proliferative phase is characterized by extensive growth of epithelial cells beneath the scab, deposition by fibroblasts of collagen fibers in random patterns, and continued growth of blood vessels. Finally, during the maturation phase, the scab slogs off once the epidermis has been restored to normal thickness. Collagen fibers become more organized, fibroblasts decrease in numbers, and blood vessels are restored to normal. The process of scar tissue formation is called fibrosis. Sometimes so much scar tissue is formed during deep wound healing that a raised scar, one that is elevated above the normal epidermal surface, results. If such a scar remains within the boundaries of the original wound, it is a hypertrophic scar. If it extends beyond the boundaries into normal surrounding tissue, it is a keloid scar, also called a keloid scar, spelled differently. So it can either be spelled keloid, K-E-L-O-I-D, keloid scar, or keloid, C-H-E-L-O-I-D scar, keloid scar. Scar tissue differs from normal skin in that its collagen fibers are more densely arranged. It has decreased elasticity. It has fewer blood vessels, and it may or may not contain the same number of hairs, skin glands, or sensory structures as undamaged skin. Because of the arrangement of collagen fibers and the scarcity of blood vessels, scars usually are lighter in color than normal skin. Development of the integumentary system. The object is to describe the development of the epidermis, its accessory structures, and the dermis. The epidermis is derived from the ectoderm, which covers the surface of the embryo. Initially, at about 4 weeks after the fertilization of the dermis, after 4 weeks after fertilization, the dermis consists of only a single layer of ectodermal skin, of ectodermal cells. At the beginning of the 7th week, the single layer, called the basal layer, divides and forms a superficial protected layer of flattened cells called the periderm. The peridermal cells are commonly slogged off by the 5th month of development. Secretion from sebaceous glands mix with them and hairs to form a fatty substance called vernix caseosa. This substance covers and protects the skin of the fetus from constant exposure to the amniotic fluid in which it is bathed. In addition, the vernix caseosa facilitates the birth of the fetus because of its slippery nature and protects the skin from being damaged by the nails. By about week 11, the basal layer from an intermediate layer of cells By about week 11, the basal layer forms an intermediate layer of cells. Proliferation of the basal cells eventually form all layers of the epidermis which are present at birth. Epidermal ridges form along with the epidermal layer. By about the 11th week, cells from the ectoderm migrate into the dermis and differentiate into melanoblasts. As you will see later, the neural crest develops into cranial and spinal nerves, among other nervous tissue structures. These cells soon enter the epidermis and differentiate into melanocytes. Later, the first trimester of pregnancy, Langerhans cells, which arise from red bone marrow, invade the epidermis. Merkel cells appear in the epidermis in the 4th to 6th month. Their origin is unknown. Let me repeat that. I think I mispronounced Langerhans. These cells, as you will see later, the neural crest develops into cranial and spinal nerves, among other nervous tissue structures. These cells soon enter the epidermis and differentiate into melanocytes. Later, in the first trimester of pregnancy, Langerhans cells, which arise from red bone marrow, invade the epidermis. Merkel cells appear in the epidermis in the 4th to 6th month. Their origin is unknown. The dermis arises from mesoderm, located deep to the surface, ectoderm. The dermis arises from mesoderm, located deep to the surface ectoderm. The mesoderm gives rise to a loosely organized embryonic connective tissue called mesenchyme. By 11 weeks, the mesenchymal cells differentiate into fibroblasts and begin to form collagen and elastic fibers. As the epidermal ridges form, parts of the superficial dermis project into the epidermis and develop into the dermal papillae, which contain capillary loops, corpuscles of touch, and free nerve endings. Hair follicles develop at about 12 weeks as downgrowths of the basal layer of the epidermis into the deeper dermis. Once again, hair follicles develop at about 12 weeks as downgrowths of the basal layer of the epidermis into the deep dermis. The downgrowths are called hair buds. As the hair buds penetrate deeper into the dermis, the distal ends become club-shaped and are called hair bulbs. Invaginations of hair bulbs, called papillae of the hair, fill with mesoderm in which blood vessels and nerve endings develop. Cells in the center of the hair bulb develop into the matrix, which forms the hair and peripheral cells of the hair bulb from the epithelial root sheath. Mesenchyme in the surrounding dermis develops into dermal root sheath and erector pili muscle. By the 5th month, the hair follicles produce lanugo, delicate fetal hair. It is produced first on the head and then on other parts of the body and is usually shed prior to birth. Most sebaceous oil glands develop as outgrowths from the sides of hair follicles at about 4 months and remain connected to the follicles. Most subduriferous or sweat glands are derived from downgrowths or buds of the stratum basale of the epidermis into the dermis. As the buds penetrate into the dermis, the proximal portion forms the duct of the sweat gland, and the distal portion coils and forms the secretory portion of the gland. Sweat glands appear at about 5 months on the palms and soles, and a little later in other regions. Nails are developed at about 10 weeks. Initially, they consist of a thick layer of epithelium called primary nail field. The nail itself is keratinized epithelium and grows distally from its base. It is not until the 9th month that the nails actually reach the tip of the digits. Aging in the integumentary system. The objective of this section is to describe the effects of aging on the integumentary system. The pronounced effects of skin aging do not become noticeable until people reach their late 40s. Most of the age-related changes occur in the proteins in the dermis. Collagen fibers in the dermis begin to decrease in number, stiffen, break apart, and disorganize into a shapeless, matted tangle. Elastic fibers lose some of their elasticity, thicken into clumps, and fray, an effect that is greatly accelerated in the skin of smokers. Fibroblasts, which produce both collagen and elastic fibers, decrease in number as a result. The skin forms the characteristic crevices and furrows known as wrinkles.